Good evening, everyone. Welcome. It's Tuesday evening. It's another NB Medical Clinic. Thank you so much for joining us this evening. Great to see so many of you on this NB Clinic. I'm going to keep the introductions really short because we've only got an hour. Time is precious. The good news, you're almost halfway through the week already. I hope the week has been going well for you. So, hello and welcome. My name is Neil Tucker. I'm a GP in Oxford. I do general practice and then I also work with NB Medical, putting together the Hot Topics course. I do the Hot Topics podcast and then putting together some of our clinics like this. So I'll be taking you through most of this clinic this evening, but I am joined by the fantastic Andy Ward from somewhere up near Leicester. Andy, how are you this evening?
I'm good, Neil, and I like to see that you've used my full name, Andrew Ward, on the slide here, which is, my mum calls me Andrew, and she happens to be staying with me at the moment, so you must have known that she was around. As Neil says, I'm in Leicester. I'm a GP here. I work in a GP service where I look after people with homelessness, and I also work at Leicester Medical School most of the time, actually. I'm nearly always there, trying to get medical students to be more empathic and better communicators mostly, which is what I love doing. And I'm going to be doing the wingman. I'm going to be in the background. Neil's going to be doing all the hard work. And I'm here answering any questions or queries you have about the presentation. If you're not sure about something, just pop it in the Q&A. Some of you have already found that. You've been putting a few messages in there. Just pop them in there and I'll pick that up with a couple of gaps in later on to go over some of your questions. So fire them in there and I'll be able to answer them for you, hopefully.
Thanks, Andy. Yeah, I mean, if you're completely new to these webinars, then that Q&A box is your way of interacting with us. It's not an open chat box, so whatever you pop in there just comes to me and Andy. Sometimes we'll just answer the questions directly. Sometimes we'll save them up. We'll have a little Q&A break at the middle and at the end. Sometimes we might reflect them back to the group. When that happens, don't worry, everything is anonymized. So do not feel like you can't ask a question. This is your forum to absolutely be able to ask those challenging questions, those questions that you might just think, oh, I'm not sure if I'm being a little bit silly here. You're not, just ask the question. And also just share your thoughts and your experiences. We're talking about lower GI conditions here this evening. So you're going to have lots of clinical experience in this area. You're also maybe going to have some personal experience as well. And if you want to, if you feel up to it and you've got something that's worth sharing, then do let us know about that as well. So let us crack on with what this is all about this evening. And we're thinking about a new diagnostic pathway. This is a primary care diagnostic pathway for lower GI symptoms. And this pathway has been a big body of work, a collaboration between a whole range of professionals and professional groups. So it's been put together by some healthcare professionals, so ones working in general practice. So hands up, I was kind of co-opted into helping out with this. This is a purely voluntary process, but I wanted to help represent general practice in this. There's lots of specialists, secondary care doctors, gastroenterologists, both in adult and pediatrics involved. There's lots of patients with lived experience, which is really, really vital to putting together something truly useful for the end user, our patients. And then there was also involvement with national professional organisations and a number of gastrointestinal charities. And ultimately, it's been endorsed by groups such as the RCGP. And indeed, I should make a special mention because Crohn's and Colitis UK are helping to actually fund this clinic this evening. So they've been part of the team that have helped put this all, have put the pathway together. Everything this evening is, for better or for worse, written by me. So the aim for this evening is to explore the utility of this pathway, thinking about it through the lens of a number of cases. And I think as we'll go through it, I mean, some of it's about the pathway, but some of it's just about reminding us about some important learning points, I hope, for lower GI conditions in general, and also just to consider how this pathway may be useful for our patients. So what's the problem? Why was this pathway needed? Well, delayed diagnosis is really common for lower GI conditions. 40% of patients with these conditions take up to 6 months before they get a diagnosis. So that's quite a long period. That's exposing them to periods of morbidity, reduced quality of life, but also potentially you're missing a window where you can maybe improve the long-term prognosis of some of these conditions as well. Part of the problem and why this happens is because up till now, we've had this siloing of conditions in existing guidelines. So we've got a guideline for inflammatory bowel disease. We've got one for celiac. We've got one for irritable bowel syndrome. We've got some stuff, some other more niche things, but they're all separate and they fail to acknowledge that there's a significant crossover of symptoms. So when someone comes to see you and I in general practice, well, actually, it could be any one of a whole range of different problems that we've got to try and kind of unpick and sort through. And of course, these different conditions require different investigations. And one of the issues there is that sometimes we'll be doing one set of tests for one condition as one guideline suggests, and you get to the end of that and you're like, well, it's not that. So then you do the next set of investigations for something else. And this sequential testing is really inefficient for us in practices. It's very consultation heavy. Also, it's not good for patients either. It's a burden on their time and again contributes potentially to delayed diagnosis. So this primary care diagnostic lower GI pathway is completely free to access. There's this fantastic website that has been put together by this team called What's Up With My Gut. So whatsupwithmygut.org.uk. You can type that in right now if you want to have a look at it and follow along. Also, you'll see on your screen, there's the resources tab. Click in there, you'll find a link directly to the website as well. Within the website, there's two separate sections, one for healthcare professionals and one for patients. And we're going to focus on the healthcare professional side of things, but I'll show you a little bit about the patient and parent pathways towards the end. So for our pathways, there's adult and there's pediatric. They're slightly different, reflecting the slightly different ways that both of these groups present, the different conditions they may present with and how we may approach investigating those problems. But both have lots of shared similar features as well. So, for example, they give some recommendations about what we should be thinking about when we're taking a history, possible presenting symptoms, thinking about red flags for cancer, other conditions to consider, a wide range of conditions, some of them the most common ones, and some of them a little bit more uncommon that perhaps we don't think about as much. The investigations we might want to undertake, and then how we refer from secondary care, and really importantly, something we need to do a lot of in general practice is, of course, safety netting. But what this pathway is not trying to do is tell you what you must be doing. It's there to facilitate clinical acumen. So you'll see, rather than going, do this, do this, do this, it kind of maybe introduces a question to us. Could it be this? Could it be this problem? Have we thought about this? When we think about investigations, it's not saying you must do all of these investigations. As we'll see, you won't want to do loads of investigations necessarily. Being designed to be suitable for a broad range of healthcare professionals. We've got a wide range of different professionals now working in general practice. It's not just the GP that patients are consulting with these days. This guideline is suitable for everyone. I hope there's things that seasoned GPs who have been a partner for 30 years or so, I hope there's some stuff that they can take away from this. Equally, if you're new into the job, you've just swapped your ambulance and paramedic training for doing some acute work in general practice. If you're a pharmacist who's transitioned into practice, whatever your role, I hope there's something here for you as well. The ultimate aim is to streamline diagnosis, investigations and referral, so it's fewer appointments and less burden on a practice, and a faster diagnosis for patients as well. It's certainly, I hope you'll find that it's an educational tool too, partly for healthcare professionals and partly for patients too. Now, let's meet our first patient of the evening. And this is Charlotte. She's 54 years old, and she comes to see you because of some lower GI symptoms. Now, she has a long-standing history of IBS, had intermittent loose stools alternating with constipation for many years. She's never had it formally assessed, never been formally diagnosed, but she's pretty sure that's what the problem is. But they've changed a little bit, these symptoms, over the past 3 months. She's experiencing a bit more bloating, some lower GI discomfort, a loss of appetite, feeling a bit more tired than usual. And generally, her stools have become a bit looser, a little bit of mucus sometimes, no blood, thankfully. All of this kind of paints a picture that something has changed somewhat. She's getting the symptoms not just as a one-off, but fairly frequently over the course of the last 3 months. She does have a history of hypothyroidism. That's being managed with levothyroxine. She's had a normal TSH on her last annual check. And she also tells you that she's recently had a FIT test through the bowel screening program, and that's come back negative. So she isn't too worried about what's driving her symptoms, but she's just wondering what's going on. So let's do our first poll of the evening. So if you're new to this webinar format with MD Medical, then we like to do some of these polls as we go through our courses. And all you have to do, you've got, well, I mean, here I put in a lot of options. Don't normally have quite this many, but you can click on the little square, which is to the right of all these different answers. And in this one, I think you can click as many different answers as you like. Because what I'd like to know is which of these following conditions do you think could be linked with Charlotte's presentation? So we've got irritable bowel syndrome, inflammatory bowel disease, celiac disease, diverticulitis, ovarian cancer, enteric infections like Giardia, small bowel bacterial overgrowth, bile acid malabsorption. Got a big differential diagnosis here. What do you think? Which of these do you think would be applicable to the symptoms that Charlotte's got? So I'll let you have a few moments just to get your answers in. There's always a bit of a delay from when we're talking to when you're hearing us, and then when you're clicking on the screen to the results coming back to us. So we have to give you a little minute. Fantastic to see so many people on this evening. Literally hundreds and hundreds of them. Wow, thanks so much for taking the time on a Tuesday evening. My wife is out playing netball with her netball team, and my kids are about to go to bed. My mother-in-law is, I can hear in the background, is just trying to start the process of getting them in bed. So if they burst in at any moment, you'll just have to excuse me. I'll try and remember to mute to mute it before I start yelling. Anyway, look, most of you have got your answers in. Let's take a little look. Okay, so, all right. Is this? I'm trying to work out I'm sure you can see the percentages on the screen now. And interesting that the most, the one that ranks highest is the one that was A, and we've got kind of like, as we've gone down the list, we've kind of like either stopped, like we've got like button clicking fatigue, or we just think it's less likely. And it is exactly a decreasing order of what you think is a potential issue, interest. Oh, Daniel, I didn't introduce Daniel. Daniel is our producer for the evening. He's up in Newcastle. He's in the background. You can't see him, but if you have any technical problems, we'll try and sort it out. I see he's just told me it auto orders. Okay, well, the world doesn't have that many coincidences in it. And as we all know, there's not that many coincidences in medicine, so that would make sense. So, okay, so we're coming out with irritable bowel syndrome, inflammatory bowel disease, celiac, and so forth at the top. That's not a surprise, because these, of course, are the most common causes of these lower GI type symptoms. So that does make a lot of sense. Now, just whilst we're thinking about this, I mean, I've got a list of the things that you think it might be, and all of them have been ticked by someone. But maybe just pop in that Q&A box. What diagnosis are you currently most concerned about for Charlotte? Not necessarily the one that you think is the most likely option, but what are you most concerned about? Pop that in the Q&A. Be interesting to see what you think. I'll come back to that in a sec. Keep your answers coming in. So, of course, medicine is rarely simple. You and I know that classic presentations of GI disease are actually uncommon. It would be lovely if people came in with the X, Y, Z to perfectly picture a condition, but it so rarely happens, particularly in the early stages, where people often have lots of very vague, nebulous symptoms. Many of these conditions share symptoms: change in bowel habit, abdo pain, bloating, rectal bleeding. This could apply to most of those conditions on that list. Or indeed, they could present with just more general symptoms. It could be outside of the gut as well, so reduced appetite, nausea, vomiting, and fatigue. So how are we going to make a diagnosis against this challenge? Just before I go on to this, I can see loads of you have popped your answers in, so thank you so much. Ovarian cancer comes out top. Yeah, that's high up on my list of things to be worried about. Bowel cancer, inflammatory bowel disease as well, coming out as the most common things that are stressing us. And yeah, I couldn't agree more. So how is this primary care diagnostic lower GI pathway going to help us? I'm going to sort of give you a bit of an overview of it and then pick out some of the really key learning points, I think. So in the guideline, you'll see that there's a list of common symptoms of lower GI conditions. I think we're all familiar with these: change in bowel habit, frequency, urgency, abdominal pain, cramping, bloating, rectal bleeding, weight loss, mucus in stools, fatty stools. And then also more systemic related symptoms, perhaps like reduced appetite, nausea and vomiting, worse with eating, mouth ulcers, ongoing fatigue. All of these could be related to lower GI conditions. The guideline does ask at the very start, could this be self-limiting? Because you and I know that many people will present in the early acute stages of an illness, and often it's not something serious. Most of the time, it's not something serious, thankfully. So it does get us to just think about, could this be something else, something we don't need to worry about too much, something that's going to sort itself out? And if it's less than 2 weeks duration, could it be something like they've just been on holiday and they've picked up some enteric bug? Is it changes in their diet or alcohol or medications? Could they have been licking the cat and they've picked up giardia? Could it be something else going on like that? Just opens the question, should we be thinking about other tests, like do a stool test to exclude infection if necessary? Maybe we just park it and we just say, okay, we think it's this, give it a little bit of time. So could this be cancer? That's the other big question. Most of you, when you're putting in that on your thoughts on this, ask the question, could it be cancer? And again, the guideline just signposts us to this idea. So it doesn't, because they don't want to make it too unwieldy. They didn't want to put in all the red flags for colorectal cancer and all the red flags for ovarian cancer. And indeed, though what we consider red flags differs depending on which part of the UK you're in. So in fact, what they've done instead is they've done something quite neat, which is just to hyperlink each country's urgent cancer pathways in the guidelines. So both for colorectal and ovarian cancer, and you'll see these little dots with a little hand in. That is a hyperlink. Click on that; it will take you to the pathways that you need. Also, just reminds us about the role of fit testing, which is something we've been talking about on the Hot Topics course over the past year, really important, and also CA125. I mean, in someone like Charlotte's case, yeah, we probably are, we do need to be thinking about ovarian cancer. Then the guideline talks a little bit about the 3 most common GI conditions: inflammatory bowel disease, celiac disease, and irritable bowel syndrome. And it gives us a few condition-specific clinical features. So I think we all appreciate there's a crossover of symptoms, but there's some things that might point us in more likely in one direction. So, for example, in inflammatory bowel disease, potential distinguishing symptoms, maybe nocturnal defecation. So, you shouldn't be your body shouldn't be waking you up in the middle of the night to have a poo. That is generally not normal. I would consider that pathological. Isn't exclusive to inflammatory bowel disease, but I've had a few nasty episodes of that myself on some holidays in Turkey where I picked up some kind of stomach bug once or twice. That's caused a bit of surprise in the middle of the night, but certainly this could be inflammatory bowel disease. Fevers, recurrent or persistent anal abscesses, extraintestinal manifestations, all of these kind of things will point us towards inflammatory bowel disease. And also, I think this is good that we put this on there. So microscopic colitis. This is a condition which affects people who are sort of older, middle-aged, basically, particularly women, particularly 50 plus. So it is an inflammatory bowel disease, but you don't get most of the typical symptoms that we associate with ulcerative colitis or Crohn's disease. You normally get this isolated, watery diarrhea. It can be unpleasant. That can lead to problems. Interestingly, if you're into that sort of thing, fecal calprotectin doesn't necessarily go up with microscopic colitis. You need the scope of biopsy to make that diagnosis. Celiac. So think about it more in patients who have Downs or Turner syndrome, but also a history of autoimmune conditions. If someone's got type 1 diabetes, they've got thyroid disease, that means it's more likely they could get celiac disease as well. And then for IBS, I think they put down here helpfully the classic features associated with irritable bowel syndrome, just as a bit of an age memoir. So Charlotte has got a number of symptoms shared by common GI conditions. We're going to move on and think about our initial investigations or management. So what would you do in this situation? Got a whole raft of options here. And again, you can click more than one option because they are not necessarily mutually exclusive. But we've got A, urgent referral to a suspected lower GI cancer pathway. B, urgent referral to a suspected pelvic cancer pathway. C, we do a full blood count. D, ferritin. E, CRP. F, celiac screen. G, thyroid function test. H, CA125. I, fecal calprotectin. J, fecal immunochemical test. K, stool MCNS. Or L, get an ultrasound of her pelvis. Which of these would you be doing to start off with? I think Daniel will be able to answer me this. Daniel, do you think that's the most options we've ever had in one of these online polls? 100%, he said. When I write these down, Daniel's actually got to type them into the system afterwards, so he probably looked at this with utter dismay. Okay, lots of options there, so I'm going to give you a few more seconds to get those answers in. Seconds, last chance, click of the button. Pretend it's like ice. You know, where you just get a bit trigger happy. I'm just going to check this and just this and this. See, someone's just saying, oops, didn't scroll all the way down before selecting. Oh no, so are you feeling disappointed now? You were like, I really thought we needed to do a CA125 and an ultrasound pelvis, but I only got the thyroid function test. Don't worry, no one can see your individual answers. Right, let's take a look. Okay, interesting. Yeah, most people are not going to refer via an urgent cancer pathway at the moment, but you do want to do other investigations. So a full blood count, ferritin, CRP, celiac screen, CA125 high on the list. Quite a lot of you thinking about a FIT test and a fecal calprotectin. Not many going for an ultrasound yet. Interesting if those of you who ticked on the ultrasound are up in Scotland, because you've got slightly different recommendations to NICE in England and Wales. I see a few of you actually saying, "Oh, I didn't know you could scroll down." Okay, yeah. This is a learning point. This, Neil, is why you don't put 10 different options on a poll on the screen. So Charlotte, she's got multiple different symptoms shared by a potential wide range of lower GI conditions. So those features, they could indicate lower GI or ovarian cancer, and most of you have already said that you're concerned about that. So that does need investigation, I think. We can do that with a FIT test and with a CA125 probably as our starting point. But also it could be irritable bowel syndrome, inflammatory bowel disease, it could be celiac, it could be other GI causes as well. And these may also need investigations. So part of this guideline is about trying to streamline care. Now, it does make the point that there is no requirement to do all the tests that it suggests for all patients. So this is very much consider which of these investigations might support your clinical assessment of that patient. And then it gives a range of possible primary care, lower GI investigations, all those ones that we would typically think about. There are no surprises on this list. Full blood count, ferritin, looking for iron deficiency anemia, CRP, celiac screen. Of course, they need to keep going with their gluten to make that a valid test. Thyroid function, renal, liver function test, and then stool test. Maybe it's a good idea to exclude infection if that's not already been done. It's always disappointing when you've spent months and months doing all these tests that doing all these tests, and in the end it turns out that they did pick up Giardia whilst they were on a holiday in Crete last year. And then fecal calprotectin and fecal immunochemical testing. A couple of specific things that it suggests. One is, let's try and avoid the patient having to make multiple trips to do all those necessary tests at the same time. That's better for our practices. It means we don't need so many appointments, and it's much better for the patient as well. And also, they just remind us about FIT testing. Although Charlotte's done that community FIT test as part of the screening program, so a negative bowel cancer screening program FIT does not mean that a patient who's got symptoms doesn't have colorectal cancer. So there are different thresholds for what they would consider positive if you're doing screening, or if it's a diagnostic test that we're ordering in general practice, which reflects the fact that if we're seeing someone with symptoms who we think should have a FIT test, well, their risk is already higher than someone who's just doing a screening program. We're already selecting those patients and their symptoms, selecting them. So we want a test that has a much better sensitivity. That's what the test that we're ordering from general practice have. So Charlotte, we organised a few tests. So this is my thoughts on it. This is what I would do. I would order a FIT test. I would do a CA125. I think about an ultrasound scan because I mean, maybe Andy will probably talk about this a little bit in the Q&A, I suspect. This isn't strictly following NICE guidelines. Up in Scotland, you would do both a CA125 and an ultrasound pelvis at the same time, because it acknowledges that CA125 has its limitations and will miss cases of ovarian cancer. Then I do a full blood count, a ferritin, a CRP, think about inflammatory diseases, celiac screen, TFTs, and I'd probably do a stool MCNS as well, so I don't want to get caught out at a later date. We can organise all of that so that she can just do it in one phlebotomy appointment. I can give her the forms, and depends how you work in your practice, but in mine, I would just give her the forms with the poo containers, and she'd go off and do that and drop them back into reception. What a lovely thing for reception to have. And then we can just do one follow-up consultation, probably over the phone. That's going to be more convenient for her and hopefully for us too. And when we've got all of that information back, the results are good news that it's a negative FIT. A CA125 is 15. I'd consider that pretty low. Her stool MCNS is negative. Her thyroid function is normal, but she does have a bit of an iron deficiency anemia. So her HB is 115 and her ferritin is 40. And a week later, it always takes a week to get that one back, doesn't it? But her celiac screen comes back positive. So we highly suspect that this is all down to the fact that she has a new diagnosis of celiac. Mid-50s, it could still happen. Then the guideline has got some recommendations about how to refer patients, and it's all about getting the patient to the right place the first time. And there's some useful recommendations here. So, for instance, in celiac, make sure they keep on eating that gluten-containing diet. Otherwise, you're going to get a false negative. In the pandemic, I think there was a phase where we would maybe make a speculative diagnosis just on the basis of a positive celiac screen. But really, the gold standard is that they need to have that confirmed with a scope and biopsy. So really, all of these patients should be referred to secondary care. Keep eating your toast until that point. Okay, excuse me, that seems like an opportune time for me to hand over to Andy and see if there's any questions or what the feeling of the room is. Hi, Andy.
Yeah, thanks, Neil. And as always, the questions all come piling in just before we come on to the live question bit. But there's some good ones coming in just now, so I'll go through some of these. If someone has a negative celiac screen a few years ago, is it worth repeating if the symptoms are still suggestive celiac? Yes, it definitely is. About 9% of patients will have a seronegative. So if you still suspect celiac in a patient and the blood test isn't supporting that diagnosis, then I would consider repeated tests in the scenario you describe. And if it's still negative and you're still suspicious, consider referring anyway in those scenarios. So remember, not everyone is picked up by the screening test, which is fairly normal for most screening tests, really. Another question here. In my area, we can't request a fecal calprotectin on a patient aged over 50. Any advice on this, please? Yeah, I mean, basically, the guidance probably is not to use it over the age of 60 because cancers are much more likely at that age, and the FIT test is the best test to use in that scenario. I think in that between 50 and 60 age group, I don't know. I think I'm sort of considering more often to do both. Actually, patients doing a poo already, they may as well send 2 poos off. I think it's okay to do that, and you're going to pick up some with the calprotectin, some with the FIT test. Definitely be doing the FIT test for sure, but in the younger age group, under the age of 45, calprotectin becomes a bit more common. I think it's a bit vague, actually, the overlap between those two. We have discussed that, haven't we? And I'll come back to Neil on that, actually. You might be able to answer a bit more about that one. We have discussed this before. When is the cut-off between calprotectin and FIT testing? And the general consensus that we came up, certainly my discussion, was you fudge it a bit and sometimes you do both. I suspect fudging it is perhaps not the best term when talking about poo. And I'm just looking, is there any point in doing a rectal examination if the FIT test is needed anyway? Yes, absolutely. It's important because you're going to pick up anal lesions or rectal lesions lower down in the rectum. So yes, you should definitely do the PR. And loads more coming in now. What I'll do is, because I don't want to overrun so that we end up overrunning tonight, I'll just answer some of these by text if you want to carry on with the next bit. Neil, did you want to say anything about that overlap between the calprotectin and FIT test? Because I never really got that clear, I must admit.
Yeah, I think that's reflective, Andy, of the fact that there is no clear answer, to be honest. I think quite a few would suggest that as we get older, it becomes more appropriate to do a FIT test because there's an increasing risk of cancer, of course. Probably a decreasing risk of it being new inflammatory bowel disease, although not impossible. I think most people would think that doing a fecal calprotectin to look for inflammatory bowel disease when you're into your 50s or 60s is probably a bit unnecessary. I mean, you may still be picking up something like microscopic colitis, I suppose, but as I mentioned before, it's not a great test for that. So yeah, I mean, I think it is a matter of just kind of fudging it a little bit, to be honest. I think there will be many times where you do specifically want to do both, because calprotectin is much better for inflammation, but is not as good at excluding cancer as a FIT test. Likewise, not everyone with inflammatory bowel disease will have a positive FIT test. So sometimes, you're doing 2 forms, 2 bottles, 2 sets of labels, bag in each hand, and off they go. Remember, when they're doing those stool samples, it's worth just sending them a link to some information about how best to do those, because I think a lot of patients would just desperately kind of like take a poo and then kind of scrape it out with the scoop, and it doesn't. That's not so good. You kind of got to have a dry sample, should we say, for it to be accurate. Anyway, that's probably enough talking about that right now. In the meantime, I can see Andy's got loads of questions now. He'll keep trying to pick those off as we just go through the next section. So we're going to have a look at another patient. This is Toby. So Toby's 3. So his parents are worried because he's had 2 episodes of blood when he's gone for a poo. It's happened about 1 week apart. At the same time, he's intermittently been complaining for a few weeks now about abdominal pain, and he has had constipation. Mostly he's getting hard stools, but also he gets some soiling and sometimes some very loose poo as well. And generally speaking, he seems to have this reluctance to go to the toilet. Probably no surprise. If he's constipated, then it's probably quite painful for him. Otherwise, as you can see, he's a well kid. No significant past medical history, no drug history. The only thing that the parents notice is that his great aunt has Crohn's disease. And partly because of that, and partly because they don't know what's going on and they're concerned, they're pushing for investigations, maybe a referral. So specifically, they want some blood tests, including a CRP and a celiac screen. Also, they want some stool tests, including a fecal calprotectin. So, okay, let's do a poll question. What do you feel is the most likely diagnosis for Toby? So I've kept this one a little bit more moderate, only 5 options. So constipation, ulcerative colitis, Crohn's disease, celiac, or irritable bowel syndrome. What do you think is the most likely cause in this scenario? Are you as worried as his parents are? I see someone just mentioned Cancer Research UK has a leaflet online about how to do a FIT test. Yeah, that's. I think that's the one that I use as well. So I must admit, I often just accurix them a link with that. But yeah, you're quite right. So some people would probably benefit with it being printed out, like you've suggested. Stick it in the bag. In fact, FIT testing in my local area, it kind of all comes in a pack already. I wonder if this is a national thing or if it's just where we are, but it comes in a pack, and you kind of have to open the pack, take out all the different little envelopes and things that you then need to label up, and as part of that, there's instructions for patients. Okay, let's have a look at your answers. Oh, yeah, I think I would agree with that. Now, be honest here. There's no judgment, but they're thinking about pragmatic, real-world general practice. Would you do all the tests that the parents requested? So yes, they all seem appropriate. Yes, anything for an easy life. And that's a bit too flippant, really, because sometimes it's just yes because you know that the parents are really going to need it, or the patient's going to need it. They're going to need it because otherwise they're going to be extremely anxious, or otherwise they're just going to keep on coming back until you eventually do it, and you might just cut to the chase. Or C, no, I'm not convinced any of these are necessary. So what would you do for Toby? Do you have that sinking feeling when you think to yourself, oh, here's a 3-year-old and I think they actually do need a blood test, and that's going to be miserable for everyone? Oh yeah, I see someone here saying instructions for FIT are in the kit. Nice tagline. maybe the rhyming is not intended. I don't know. If it's not, that's yours. Own it. Okay, let's take a look at your answers. Okay, so the majority of us are going, no, I'm not convinced that these are necessary. I see someone in the notes saying it's not fair to do a blood test on a child who can't consent. You need to have a good reason. Yeah, I think that's probably true. Okay, so just going to have a quick think about the pediatric pathway in this overall guideline. So this pediatric pathway is the same design as the adult pathway, so a lot of it shares kind of common features here, but there are differences, such as the symptom list reflects there are different presentations in children than there may be in adults. There's a lot of shared ones as well, but there's certainly some different ones. And then you'll see when it's highlighting the most common conditions, inflammatory bowel disease, celiac, rather than have irritable bowel syndrome there, which I think we'd all agree would be an uncommon diagnosis for us to make in young children, then it says, well, could it be another GI condition? And there are other conditions that could be more common. So, for example, could it be constipation? Could it be functional? Could it be a food allergy or intolerance? Could it be constipation and overflow diarrhea? So then let's just sort of think a little bit more broadly. How does the pathway actually help us? Well, I think that it can help us with what the presenting symptoms suggest the problem may be, suggest what it's unlikely to be, maybe indicates towards a diagnosis, and if investigations are appropriate and useful. And I think that can be quite helpful when we've got maybe those slightly more tricky consultations where someone really wants something and we don't think, actually, I don't think that's quite the right thing to do. And I think sometimes it is useful to have these guidelines to fall back on, to add weight to our discussion with a patient, to say, well, actually, you know what, I don't think this is indicated and this is the reason why. So, for example, these parents are requesting for Toby that we do a fecal calprotectin. Now, I didn't know this. I mean, I'll be honest, I haven't often ordered a fecal calprotectin in young children, but there's sometimes the back of my mind, I kind of think, well, I wonder if this could be some kind of inflammatory process going on. Maybe it would be helpful. So I didn't appreciate that calprotectin levels vary depending on age. Or there are actually different age cutoffs for what you might consider a positive result or not. But the guideline just advises us avoiding under 4s unless it's really strongly indicated, because actually it becomes quite difficult to interpret. Indeed, what I take from that is, well, you know what, I probably don't want to be doing it myself in general practice. If I think this kid needs a calprotectin, probably I should be referring them for a pediatric review and let them make that decision. But equally, in the case of, for example, Toby, I think it also is quite helpful to say, you know what, this test is not going to be appropriate in a child of his age. So Toby, we explained that the most likely diagnosis is constipation. He's already got an existing history of constipation. He's obviously stool withholding. The soiling is likely to be down to intermittent overflow diarrhea. The bleeding is probably because he's got a minor little fissure from when he does have one of those big poos passing. All of that must be very painful. And of course, that sets off that classic sort of cycle that we see developing in children with constipation. The good news is he's otherwise well. It doesn't suggest that there's some major underlying problem for him. So I think most of us would suggest at this stage investigations are unlikely to be helpful. And I think the pathway helps support that conversation about appropriate investigations. We, of course, need to manage the constipation effectively for Toby. Of course, we can do that in general practice. We're very, very good at that. We also need to be mindful about safety netting. So that brings us on to the sort of the last section of the guideline. And we shouldn't forget about safety netting, really, really important part of our work, especially in general practice when we're dealing with lots of uncertainty. We're sometimes using time as a diagnostic tool. Really important that we safety net appropriately so patients know what they should be looking out for when they need to come back and see us. So there's specific guidance both for the adults and the pediatric pathways. The guidance is slightly separate there, reflecting, again, the likely underlying problems and the kind of particular high-risk conditions that we don't want to miss. General considerations for us as clinicians. So persistent or changing symptoms, that's going to need reassessment. So it's no good having someone who comes to us and said, oh, I've had 3 months of symptoms. We do some tests, the tests come back negative, and then they've still got their symptoms and they never get better. Just then kind of like pushing them out into the world with no kind of follow-up. It's not a great place to be. Let's remember, no test is perfect. It's always potential that we're going to miss something, or indeed that something changes. So anyone who's got persistent or changing symptoms, they're going to need a reassessment, and potentially they're going to need referral as well to clear up what the actual diagnosis is. And I think there's kind of a general feeling that if you've got, let's say, ongoing diarrhea and you don't know what it is, that's going to need a scope, right? You're going to need to clarify what's going on. Severe symptoms, they might need an urgent referral. So they put the sort of normal like sort of referral pathways in this form, but some people might have horrendous first presentation of inflammatory bowel disease. You know, they may be getting 8 to 10 bloody stools a day. Maybe they're not kind of like super acutely unwell, but you and I know that if we leave them for 6 months to get to see the gastro on a normal referral, they're going to be unwell. So sometimes we're going to need to just push for that referral a bit. Sometimes we're going to need to pick up the phone, depending on the scenario. And there's a few other nice tips that I picked up from here. So things like a false negative celiac screen. We already mentioned were they eating, were they still on a gluten-containing diet? Really, really important. But of course, there's lots of different things that you can get false negatives with. And I've mentioned this before on these kind of GI clinics that we've done in the past. So not uncommon to get negative, particularly blood inflammatory markers with inflammatory bowel disease. So you could get a completely normal CRP despite the fact that they've got raging ulcerative colitis and they're pooing blood multiple times a day. So don't be necessarily reassured by the results that we're seeing. There's a few other things to pick up on. So in terms of safety netting, they talk about if symptoms suggest, consider other causes. So it could be outside of the lower GI system. It could be an upper GI cancer. It could be something that's non-site specific. And so maybe you need, if you have access to one of these sort of diagnostic community hubs where you can do a urgent cancer referral for non-specific symptoms. And they get a CT of their sort of chest, abdo, pelvis, and anything else that they need. And that can be really, really useful. This one is one that has caught us out in the practice in the past. I mean, it's not that common where I work, maybe more common where you work, but chronic diarrhea. Just have a little think about, could it be HIV? Have we checked for that? That should be on our radar. And certainly we might want to just be taking a sort of a bit more of a history along those lines for some in some areas. And could it be another lower GI condition? And this guideline focuses on the 3 most common, but there are a whole range of other lower GI conditions. So we've already mentioned microscopic colitis. We haven't talked much about bile acid malabsorption. So this is an interesting one where people tend to get lots of sort of looser stools, fatty stools, quite common after cholecystectomy, but of course it can present in earlier in life as well with no surgery whatsoever. So that's something to think about. Diverticulitis, particularly as people get older, small bowel bacterial overgrowth. I'll be honest, I don't really know much about small bowel bacterial overgrowth or how you diagnose it or how on earth you treat it if you think it's there. But it could be something to consider. That might require a bit more specialist input. Pancreatic insufficiency as well. Fecal elastase is the primary test for that. There's lots of useful information on this guideline. So I think that covers most of the healthcare professional side of things, but it's worth just having a look at the patient side of the pathway as well, because there's a parallel website for patients based on the professional clinical pathways. And I think this is really, really important and really useful for patients. It can help them understand what's causing their symptoms, how to make the most of a consultation. That's really important because it can help train patients so they understand what we need to know and how they can communicate that efficiently, which is, I think, a really nice idea. What we will want to know and need to address in a consultation, that helps prime them for those questions and to think about those issues, what investigations we may recommend and why, or indeed maybe why not. And of course, what a specific diagnosis means. And there's lots of links to useful resources about all the conditions that are mentioned in the guideline. And just to give you an overview of one of the flow charts that is used in the patient pathway. So what symptoms to look out for, what we might be asking, and then what we're thinking about. I mean, you'll see it mirrors a lot of what we do, but it also then links to further explanations about all of these conditions and all of these tests, which is, I think, really, really useful. Educating people about what to look out for is really, really important. So you can access that in just follow the same website. So What's Up With My Gut, and you'll see on the homepage that you can go down the healthcare professional patient pathway. So I've been sending patients links to that when they need information. Okay, let me hand over to Andy for any of those questions or comments or thoughts that's been coming in.
Thanks, Neil. It's been a little bit frantic. I've got very tired fingers now. I'm really sorry to anyone whose question I've not been able to answer. I've not been able to get through them all. There's been so many good ones. Good question here. I have a patient with HIV. You mentioned HIV and diarrhea. Getting nowhere and with debilitating chronic diarrhea. What could be the underlying disorder here? Sometimes bacteria infections or protozoa or fungi. Obviously, they're going to be more prone to sort of unusual infections. But I think there can be some autoimmune things that go on there as well. And maybe sometimes some damage to the autonomic nervous system as well can lead to problems. And maybe some of the medications they're taking as well. It's pretty grim for someone who's got a pretty nasty diagnosis to have to live with anyway. So I would say get the gastroenterologist to help a bit more, perhaps, in that case, if you can, just put some real pressure on them. Let's follow any other questions on here. Diverticular disease doesn't seem to feature highly in the pathway. Has it gone out of fashion? Well, you probably think it's probably getting more frequent with the aging population and poor diets. I'm not sure why it's not in the way. I suppose it's looking really, maybe seeing that more as a clinical diagnosis that you make in older age groups with the symptoms and the signs, the abdominal tenderness maybe. I don't know, and I'll come back to you. Since you wrote part of these guidelines, Neil, that's on you, that question. Why is diverticular disease not featured highly in the pathway? I'll come back to that one in a minute. Couple more come in. Oh, these are more people saying thank you. Is there any point in doing a fit test in someone presenting with rectal bleeding? I'm really glad we got this question. Yes, there is. You can still do a fit test in someone with rectal bleeding. It picks up a byproduct of the blood, so it doesn't actually. So there's actual fresh blood there. It won't affect the fit test. So yes, carry on doing fit tests in people with rectal bleeding. And I think we're coming to the end there, aren't we, Neil? So I'm going to hand back to you you can answer that tricky question about diverticular disease there, Neil. So back to you on that one before we wrap up.
Yeah, thanks, Andy. Yeah, that's it. Yeah, it's a very good point about diverticulitis or diverticular disease. Part of me wonders if it's because we didn't have a lot of lower GI surgeons contributing to this guideline, and it's mostly gastroenterologists and some primary healthcare professionals. But actually, I think really probably because the main presenting features that we're thinking about are not don't necessarily present in quite the same way. So you might get abdominal pain, but those sort of more sort of shared features like diarrhea, bloating, that kind of stuff, I wouldn't typically associate that with a sort of your average diverticulitis presentation. Not impossible, but perhaps not quite what not quite in the same league in terms of how we're going to approach this. So, okay, thank you so much for everyone who's joined us this evening. We had pretty much 400 people come in this evening. That's great. Just a reminder about the website. You can find that once again in the resources section. So you'll be able to watch this back, and if you want to share this with your friends, if you think this is going to be useful for them, then they'll be able to come back and watch this on demand at any point from tomorrow onwards, and you'll see all of the stuff in the resources section still then as well. If you're not signed up to NB Plus, just to highlight, this is our subscription service where you can come on all of our NB Medical live webinars and get all of our on-demand webinars and loads more stuff on the website as well for just over £300 a year. Plus, up till Monday, we've got a discount on that as well. I mean, it's already a bargain. Get it while it's cheaper. We've got a dozen courses that you can come on now. It's absolutely fantastic. Our next clinic is going to be on the 15th, so Tuesday the 15th of October, same time, 8 p.m. That's going to be looking at gynecological cancers. And don't forget, you can always get in touch, Neil or Andy at mbmedical.com or hottopics@mbmedical.com. And you're going to get a certificate of attendance that's going to for coming on here. But what we would really love you to do is give us your feedback. We're always trying to improve these courses based on your feedback. And as we finish this, you'll see a little pop-up coming on your screen. It's really quick. Just what did you think of this evening? What would you like to see in the future? And specifically, actually, just because I think I may be doing another clinic later on in the year on inflammatory bowel disease, what topics would you like to see in future webinars on that? So if there's any burning questions you've got about that, put that in the feedback as well. That would be good to see. That may influence what we do later in the year. And if you want to provide feedback on the whole pathway, then I think in the questionnaire, there's also some links to how you can do that too. So the organizations that have helped put this together, they do want your feedback to see how it uses in the real world and how we can always improve things. We always want to try and make things better. On that note, I'm sure you are all making the world better. Thank you for joining us this evening. Have a great rest of your night. Take care. Bye-bye.